Hello everyone, I am Dr. Trupti and you are watching my YouTube channel Enjoy Biochemistry. In the video lecture series on vitamins, today we are going to learn about vitamin K. Let's begin this topic with a case study on vitamin K deficiency. Here is a case of 1-year-old baby boy who was brought to the hospital with history of easy bruisability and bleeding in response to minor trauma. There was history of mucosal and subcutaneous bleeding such as epistaxis, hematuria, gum bleeding, oozing from vaccination site. Laboratory results showed prolonged prothrombin time. And here are various questions related to this case study. The first question is, what is the probable diagnosis and justify? Second, write the RDA, dietary sources, digestion, absorption and transport of the deficient molecule. Describe the functions of deficient molecule. Explain the biochemical basis of clinical features of the disorder. What are the causes of deficiency of the molecule? Why is prothrombin time prolonged in this condition? Name the antagonist of the molecule and their mechanism of action. Write the therapeutic uses of the molecule. So in today's video, we are going to learn about the RDA, dietary sources, digestion, absorption and transport of vitamin K, its biochemical role, the biochemical basis of various clinical features of the disorder, what are the causes of deficiency, and what are the antagonists of vitamin K, and what is the therapeutic use of vitamin K. Vitamin K is a fat soluble vitamin. It is required for activation of various blood clotting factors like factor 2, 7, 9 and 10. Factor 2 is prothrombin, factor 7 is proconvertin, factor 9 is called as Christmas factor and factor 10 is called as Stewart power factor. So this vitamin K is required for activation of these four factors because these four factors are synthesized in the liver in zymogen form, that is the inactive form, and for their activation vitamin K is required. And vitamin K is called as anti-hemorrhagic factor or coagulation vitamin. So K stands for the name of vitamin, that is vitamin K. It is the only fat soluble vitamin that acts as a coenzyme. Now the vitamin K derivatives, they all are naphthoquinone derivative. So you can see here this is 2-methyl-1,4-naphthoquinone because at the second position methyl group is attached and it has a naphthoquinone ring and isoprenoid side chain is attached at the carbon number 3. There are three types or three forms of vitamin K: vitamin K1, K2 and K3. Vitamin K1 is called as phyloquinone. It is the natural form of vitamin K. It is derived from the plant sources. The other name is phytomenadione or phytonadione. This is the structure of vitamin K1. So here the side chain has 20 carbons. K2 is minaquinone, which is also a natural form of vitamin K. This minaquinone can be synthesized by intestinal bacterial flora and it can be also derived from the various animal dietary sources. This is the structure of minaquinone. Here the difference is only in the side chain, that is it has 30 carbon side chain. The third form, that is K3, it is called as minadione. It is the synthetic form, it is the water soluble form. And this is the structure of vitamin K3. Here only hydrogen is present as a side chain. So these are the three forms of vitamin K: vitamin K1 phyloquinone, vitamin K2 minaquinone and vitamin K3 minadione. Now let's see the dietary sources and RDA of vitamin K. So there are these two forms, vitamin K and vitamin K2. They are provided through the diet. Vitamin K1 phyloquinone, we get it from the plant sources like spinach, cauliflower, cabbage, peas, various beans. And vitamin 2, that is minaquinone, from the animal sources like egg, meat liver and various dairy products. The best indicator of vitamin K nutritional status is the measurement of vitamin K1, that is phyloquinone. The RDA in adult is about 50 to 100 microgram per day, that is 1 microgram per kg per day. And even if the diet does not contain this vitamin, intestinal bacterial synthesis will meet the daily requirements provided the absorption is normal, because this vitamin K, it is synthesized by the intestinal bacterial flora. Being the fat soluble vitamin, this vitamin K is absorbed along with the fat in intestine. So after dietary intake, it is digested and absorbed in the small intestine. Bile salts are required for digestion and absorption. And once it is absorbed in the intestinal cell, it is incorporated in the chylomicron, which is a lipoprotein, and this lipoprotein carries this vitamin K through the lymphatics. Then in the circulation it reaches to liver. Then it is incorporated in the VLDL and it is transported from the liver, and then it is converted into LDL, and this LDL carries this vitamin K in the circulation. The vitamin K3, that is menadion, it does not require bile salts for digestion and absorption. It is water soluble. It is directly absorbed in the portal vein. And this vitamin K, it has an insignificant storage. It is not stored in the body, and that's why it is the first fat soluble vitamin to be deficient if there is acute fat malabsorption. Vitamin K performs various biochemical functions, and the most important role is in blood coagulation. This vitamin K is responsible for post-translational modification of various clotting factors like factor 2, 7, 9 and 10. It is also involved in activation of anticoagulants like protein C and S, which prevents excessive coagulation. It is also involved in inactivation of factor 5 and 8. Mineralization of bone is also important biochemical function of vitamin K, because this vitamin K is involved in the activation of proteins like osteocalcin, matrix, gamma carboxyglutamate protein and periostin. It has a role in electron transport chain and oxidative phosphorylation, because the vitamin K is structurally related to the ubiquinone, which is the component of electron transport chain. Now let's see how activation of clotting factors occur in hepatocytes. The clotting factors, they are synthesized in the liver in their inactive form, that is the zymogen form, and they have gamma glutamic acid residue, and they undergo post-translational modification, that is gamma carboxylation, by the action of enzyme gamma glutamyl carboxylase. This reaction requires molecular oxygen as well as carbon dioxide, and there is formation of mature clotting factors and which have carboxyl group attached to the gamma glutamic acid, and now it becomes gamma carboxyglutamic acid residue, which is also called as GLA. So the activation of immature clotting factors or inactive clotting factors into active clotting factors requires gamma carboxylation, and this process requires vitamin K as a coenzyme in its reduced form, that is hydroquinone is a reduced form of vitamin K which acts as a coenzyme here, and this vitamin K is used up and to form 2,3-epoxide form of vitamin K. Now to regenerate back this reduced form from the 2,3-epoxide form, the intermediate is formed, that is the quinone form of vitamin K, and to form this quinone form, vitamin K 2,3-epoxide reductase enzyme is required, and it also requires reduced lipoic acid which provides the thiol group which is required for formation of this quinone, that is vitamin K. Now from this quinone the reduced form is synthesized with the help of enzyme quinone reductase, and this process requires NADPH. Now let's see how the activation of clotting factors leads to blood coagulation, and this process is most clearly understood for factor 2, that is prothrombin. So the each gamma carboxyglutamate residue of clotting factor, that is prothrombin, it contains two negative charges, two carboxylic group, and these two carboxylic group, they chelate with the positively charged calcium ion to form prothrombin calcium complex. Now this prothrombin calcium complex binds to negatively charged phospholipids which are present in the membrane surface of platelets, and now here after formation of this complex and binding of this complex to the phospholipid on the platelets, the prothrombin is converted to thrombin, and this thrombin in turn converts fibrinogen to fibrin, and thus it is involved in the clot formation during bleeding. There are two antagonists of vitamin K, warfarin and dicumarol. What is the mechanism of action? Both warfarin and dicumarol, they inhibit the conversion of 2,3-epoxide form of vitamin K into quinone form of vitamin K. And why this reaction is important? It is important to form the reduced form of vitamin K, that is hydroquinone, which act as a coenzyme in this gamma carboxylation process. And if the warfarin and dicumarol inhibit this step, the reduced form cannot be produced, which is required for this carboxylation. So there will be no activation of clotting factors and there will be no coagulation, and thus both warfarin and dicumarol, they act as anticoagulant and they are vitamin K antagonist. Warfarin is also used as a rat poison. Vitamin K also plays a role in mineralization of bone because gamma carboxyglutamate is necessary for functional activity of bone protein like osteocalcin. This osteocalcin is a small protein which is synthesized by osteoblast, and its synthesis is induced by vitamin D. And the proteins like osteocalcin, matrix, GLA protein, periostein, these are the gamma carboxyglutamate rich proteins which are formed by vitamin K dependent gamma carboxylation. So this process of gamma carboxylation is required for the activation of these bone proteins. And these proteins are involved in the binding of osteocalcin to hydroxyapatite crystals of bone, and this process is required for the bone mineralization. And osteocalcin also contains hydroxyproline, and the formation of which requires vitamin C. So vitamin C is also required here, and that's why this osteocalcin is dependent on both vitamin K as well as vitamin C. And the uncarboxylated osteocalcin leads to decreased bone density and susceptibility to the bone fracture. So if there is not proper carboxylation or vitamin K deficiency, it leads to decreased bone density and there is increased risk of fracture. Vitamin K also has a role in electron transport chain because the component of electron transport chain, that is ubiquinone. This ubiquinone, it transports the reducing equivalents from complex 1 and complex 2 to complex 3, and this is structurally similar to vitamin K, and that's why the vitamin K plays a role in electron transport chain and oxidative phosphorylation. Coming to the vitamin K deficiency. Deficiency is uncommon because this vitamin K is widely distributed in nature and it is also synthesized by the intestinal bacteria which are sufficient to meet the needs of body. But the deficiency is seen in the person on prolonged antibiotic therapy, which will destroy the intestinal bacteria. It can also be seen if there is malabsorption of lipids due to various conditions like obstructive jaundice, celiac sprue, steatorrhea, chronic pancreatitis. If the person is suffering from gastrointestinal infections with diarrhea, it will destroy the bacterial flora and it leads to vitamin K deficiency. Then the vitamin K antagonists like warfarin and dicumarol, they are used for anticoagulant therapy and they can lead to vitamin K deficiency. And it can also be seen in the newborns and it can manifest as hemorrhagic disease of newborn. And because these infants have relative vitamin K deficiency, and the various reasons are poor passage of vitamin K through placenta, lack of hepatic stores, absence of intestinal bacterial flora and limited oral intake, because breast milk has very low levels of vitamin K. So all these can be the causes of deficiency of vitamin K. What are the deficiency manifestations of vitamin K? Vitamin K deficiency is manifested as hemorrhagic disease in newborn, especially in the premature babies, and this is often called as vitamin K deficiency related bleeding, that is VKDB. And various clinical features are bruising tendency, ecchymotic patches, then mucous membrane hemorrhage, post-traumatic bleeding, internal bleeding. Even with the minor injuries there is profuse bleeding. And here the prolongation of prothrombin time occurs, that is prothrombin time is prolonged in case of vitamin K deficiency, and the clotting time is delayed. As per the WHO recommendation, all newborns should be given prophylactic doses of vitamin K, that is 1 milligram intramuscularly, preferably within 6 hours after the birth. How the vitamin K deficiency is assessed? It can be assessed by estimation of serum prothrombin time and activated partial prothrombin time, by estimation of serum vitamin K levels and serum prothrombin precursor level, that is PIVKA2 levels. Now this prothrombin time, it is increased in the severe deficiency states. Measurement of prothrombin time is one of the liver function tests. When the liver is not functioning properly, it will not be able to synthesize the clotting factors, and it will lead to prolongation of this prothrombin time. But this prothrombin time is also prolonged in vitamin K deficiency. Now how to differentiate the prolongation is because of liver disease or if it is due to vitamin K deficiency? For that, the PT is measured before and after the administration of vitamin K. So what happens in the liver disorder? In liver disorder, the administration of vitamin K fails to restore the PT to normal levels. Whereas if it is due to vitamin K deficiency, PT is restored to normal level. And this test is done before undertaking any surgery on the jaundiced patients to prevent excessive bleeding during surgery. Vitamin K deficiency is also assessed by the estimation of vitamin K levels, and normal serum phyloquinone level are 0.2 to 1 nanogram per ml. If it is less than 0.15 nanogram per ml, it shows low tissue body stores. Now the third parameter is serum PIVKA2 levels, that is, it is protein induced by vitamin K absence. It is also called as des gamma carboxyprothrombin or protein induced by vitamin K absence, that is PIVKA, and it is the functional marker of coagulation. How vitamin K deficiency is treated? In neonates with birth weight less than 1500 gram, 0.5 milligram of vitamin K is given intramuscularly, and in adults 5 to 10 milligram of vitamin K is administered parenterally for immediate effect. What is the therapeutic use of vitamin K? Vitamin K acts as an antidote to the poisoning by dicumarol type of drugs, and the quinone form of vitamin K is given, and it will bypass the inhibited step in the vitamin K cycle, which is catalyzed by 2,3-epoxide reductase, because we know that dicumarol and warfarin, they inhibit the step of vitamin K cycle, which is catalyzed by this vitamin K 2,3-epoxide reductase, which is responsible to convert the 2,3-epoxide form into quinone form. So if this step is bypassed, then we can get the reduced form, that is hydroquinone form of vitamin K, which acts as an coenzyme in the vitamin K cycle, which is required for the activation of clotting factors. Coming to the hypervitaminosis K, naturally occurring vitamin K, they have no harmful effect, but the prolonged intake of large doses of minadion, they can cause hemolytic anemia, hemolytic jaundice and kernicterus, and it is due to the toxic effect of minadion on red blood cell membrane. So in today's video, we have studied about various forms of vitamin K, then dietary sources, RDA, biochemical functions, deficiency manifestations, antagonist of vitamin K, therapeutic uses, and hypervitaminosis D. And in the beginning, we have seen one case, and now I hope after going through this video, you are able to answer all the questions. Now let's see one more case study in adult. A 50-year-old male presented with complaints of bleeding gums and nose. So there is bleeding tendency. He was a known case of ischemic heart disease and hypertension, and history revealed that he was on the warfarin therapy, and warfarin is an anticoagulant. A few days back, he had a lower respiratory tract infection. He had prolonged antibiotic therapy. So prolonged antibiotic therapy leads to loss of microbial flora. So one of the reason for vitamin K deficiency, again warfarin is vitamin K antagonist, and laboratory investigation showed prolonged prothrombin time, and liver functions are within normal range. So here it is a clear-cut case study of vitamin K deficiency. Probable diagnosis is vitamin K, and in the justification you can write the clinical features like bleeding tendencies, the patient's history that he had ischemic heart disease, and for that he was on the warfarin therapy, which is the vitamin K antagonist, and prolonged antibiotic therapy is also there, and on investigation PT is prolonged. And what is the biochemical basis of disorder? It is because of the patient, the warfarin is vitamin K antagonist and prolonged antibiotic therapy. Characteristic clinical features of the disorder already given: bleeding gums and nose, so there is bleeding tendency is there. Significance of prolonged antibiotic therapy I have already mentioned, because it leads to loss of intestinal microbial flora, so there is vitamin K cannot be synthesized in the body. Name the investigations required to diagnose the condition. So we know that prothrombin time is already measured, so there are vitamin K levels can be measured and prothrombin precursor can be measured. How patient can be treated? By giving vitamin K. Now let's see some multiple choice questions related to vitamin K. The first question is, vitamin synthesized in the intestine is it vitamin A, C, D or K? We know that vitamin K, that is minakinone, it is synthesized by the intestinal bacterial flora, so the answer is vitamin K. Vitamin K acts as a coenzyme for enzyme carboxylase, decarboxylase, hydroxylase or oxidase. Now we know that reduced form of vitamin K acts as coenzyme for gamma carboxylation of clotting factors 2, 7, 9 and 10. So it is required for carboxylation reaction. So here the answer is the enzyme carboxylase. Dicumarol is an antagonist to riboflavin, retinol, vitamin K or pyridoxine. So it is the antagonist to vitamin K. It inhibits the formation of reduced form of vitamin K from the oxidized form, that is epoxide form. Deficiency of vitamin A can occur in the following conditions except: does it occur following gastrectomy or after prolonged antibiotic therapy? Yes, it occurs after prolonged antibiotic therapy due to loss of microbial flora. It can occur in conditions of obstructive jaundice, and dicumarol is the antagonist. So administration of dicumarol also lead to vitamin K deficiency, but it does not occur because of gastrectomy. So it does not occur in following gastrectomy. So here the answer is A, that is it does not occur after gastrectomy. Biochemical function of vitamin K is for converting proline to hydroxyproline. So for conversion of proline to hydroxyproline, vitamin K is not required, vitamin C is required. Conversion of prothrombin to thrombin needs calcium. Gamma carboxylation of clotting factors require vitamin K. It is not required for inhibition of lipid peroxidation in biomembrane. Here vitamin C and vitamin E plays a role in inhibition of lipid peroxidation. So here the answer is gamma carboxylation of clotting factors. Vitamin K is inhibited by, is it inhibited by isoniazid, methotrexate, dicumarol or avidin? So it is inhibited by dicumarol. It is the antagonist of vitamin K. Isoniazid, it is the anti-tubercular drug. It leads to pyridoxine deficiency. Methotrexate is a folate antagonist, and avidin is a biotin antagonist. If you find the content on this channel useful, please subscribe to this channel, like and share the videos and help this channel to grow. Thank you for watching and happy learning.